So good morning, everybody, and welcome to Department of Surgery Grand Rounds, October 30th edition. I think we have a very interesting and timely topic today, being presented to us by two of our colleagues, one whom many of you know very well, Dr. Amal Bessissow, who is the director of our pre-op clinic and who has done her training at McGill in internal medicine, and then extra fellowship in perioperative medicine at McMaster. And we've been working closely with them all for many years now in our pre-op clinic, and we're really grateful to have you at the clinic and
Thank you.
presenting to us today. And I think you are joined by your colleague here, Dr. Quinn Pon, who is one of our anesthesia residents, who did, in fact, his bachelor's in physiology and pharmacology at the University of Saskatchewan, and is one of our residents here at McGill. And I'm sure many of you have run into him in the OR and in other spots. So I'm looking forward to hearing about this topic, and thank you for being here today.
Thank you very much for the invitation. I'm just going to share my screen in a second. So I'll share my screen because my PowerPoint is not showing up. Oh, here you go. Got it. Okay. So I hope you can see my screen, and I'm just going to put here the presenter view.
Yeah, you see it fine. Yeah.
That's good for you. Amazing. Very good. So thank you again. Good morning, everyone, and thank you for the invitation. It's a great honor to be here. I would like to also thank Dr. Pon, who agreed to present with me because I thought that the perspective of anesthesia is very important in this topic. And Dr. Pon, 2 years ago, presented on that same topic at the Periop rounds, and he did an amazing job. So that's why I contacted him again and to ask him to present with me on this topic. We have no disclosure to report. The objective of today, for the first about 10 minutes, I'll talk to you about the evidence supporting GLP-1 receptor agonist-based therapy in chronic diseases, and just to give you kind of a background of why we're using it, how they work. I think it's important to understand it in order to be able to discuss the perioperative impact of that drug category. And then we will review the current recommendation in the perioperative care of what we should do with these novel, if we can say, medications. So first of all, the GLP, it's glucagon-like peptide 1. It's an amino acid long peptide hormone that is secreted by the intestinal epithelial endocrine L cells. And what they do is that they go on the receptors in order to create or create a cascade of events. And those receptors can be found in many kind of tissues, including the pancreas on the islet beta cell, the gastric mucosa, small bowel, the heart, the kidneys, the hypothalamus, and more. So the way it works is the following. This is in a healthy patient. So let's say you eat a nice hamburger, and once the hamburger gets to your stomach, it will trigger a cascade of events. The first thing that it will happen, well, one of the first thing that will happen is that the L cells and the K cells in the small intestine will produce GLP-1 and GIP. GIP is glucose-dependent insulinotropic polypeptide. And why I'm showing you this is because you'll see later that the drugs that we are using, these are two really target therapy actually that we are using. So both together, the GLP-1 and the GIP will have an impact, as you can see where the circle is, they will have an impact on if you look at number 3, which is pancreas secreting more insulin, that's number 1. Number 2, it will have an inhibitory effect on the stomach to cause early satiety. Number 5, it will decrease the production of carbohydrate by the liver. And number 6, it will tell the brain, hey, you're too full, stop eating, so decreasing appetite. Okay, so it really does many have many targets on the body once you eat. And those two mechanisms, so the GLP-1 and the GIP, are what we call the incretin effect. And they are mainly affecting diabetic patients mainly. So once we have those inhibitory effects by the GLP-1 and the GIP, what it triggers is that because there's more insulin, because there's less glucose production, there's definitely an impact on the plasma glucose, and as I mentioned, also impact on the brain and the stomach. So overall, what the impact of GLP-1 overall impact of GLP-1 is the following. So if we start with the brain, it will increase satiety, reduce appetite, and decrease food intake. On the pancreas, it will cause insulin secretion. On the adipose tissue, decrease insulin resistance, increase energy consumption, and increase lipolysis. The stomach, gastric emptying decrease, and GI motility decrease. And on the liver, it will decrease the content of lipid and decrease hepatic steatosis. It sounds like a very interesting drug, right? So we'll see what the result and what are the effects of the study have shown one use. Important thing to mention is that we have the GLP-1, and as you notice in my title, I put GLP-1 receptor agonist. It's actually slightly two different things. The GLP-1 that I just discussed is secreted by our own body and has a very short half-life of 1 to 2 minutes, and it's rapidly degraded by the enzyme DPP-4. The synthetic one, which is that we find in drugs, is actually resistant to the enzyme DPP-4 degradation. It has a longer half-life, and that we will discuss how long it is, because that it's a challenge. And it binds to the GLP-1 receptor and stimulates the same cascades of events at the endogenous GLP-1. And obviously, because of that, it is easier to use for clinical purpose. So there's two types of therapy that are GLP-1 based therapy. So we have the GLP-1 receptor agonist, and we have a dual receptor agonist, one that are combined in one molecule, which is in one drug, sorry, the GLP-1 and the GIP that I mentioned to you earlier, which is the glucose-dependent insulinotropic polypeptide. So the GLP-1 receptor agonists are the agents such as semaglutide, dulaglutide. These are liraglutide. So these are all receptor agonists only. The new kid on the block is the tirzepatide. So this is a dual. It basically has both receptor agonists, GLP-1 and GIP. And because of that, studies have shown that it actually enhances efficacy in weight loss because it targets multiple metabolic pathways. So it makes sense, and I'll show you how extensive actually the weight loss can be. The property of those medication is that they are metabolized in the liver and the kidneys. So to keep in mind, when there's liver failure and kidney failure, they're excreted by the kidneys. And there's formulas that are subcutaneous or PO. Most of them are subcutaneous, and you can either take them once a day or once weekly. And these are the most kind of common, actually, they're all the agents that we have on the market. And as you can see here, these are the agents with the trade name, FDA approved for diabetes, FDA approved indication for obesity, and FDA approved for cardiovascular risk reduction. So if we go down to the semaglutide here, we have the Ozempic, the trade name, and Wegovy, the trade name. And these have been approved for this medications category has been approved for type 2 diabetes, for obesity, as well as for cardiovascular protections. Is that the only one? No. We have liraglutide, Victoza, Sazanga. These have also been approved for all category. And as I mentioned to you, there are oral formula as well. So now we have oral semaglutide that is taken once a day. It's called the Rybelsus, and it has been approved now only for type 2 diabetes. And the new kids on the block that I'm sure you heard about in the news is the tirzepatide, the Mounjaro, that has been mainly approved for diabetes and obesity at this point. Okay, so you can see that most of them are actually once weekly, with exception to the liraglutide that is actually daily, the one that we use. So let's review some of the evidence, being mindful of the time, not taking too much of your time, but just to tell you when did we start using them for diabetes, obesity, and other indications. So there is currently clear evidence that the GLP-1s in diabetes improve outcome by reducing hemoglobin A1C and plasma glucose, okay? And this is a systematic review of over 1,400 patients. And all kind of GLP-1 will reduce your hemoglobin A1C, will reduce your plasma glucose, and compared to placebo, they will all reduce your weight, the weight. In terms of side effects, mainly GI symptom, nausea, vomiting, abdominal pain, and hypoglycemia in some cases, especially if you combine them with other anti-diabetic medications such as oral hypoglycemic agent. And in this systematic review, there were no difference between short-acting and long-acting GLP-1. So how about obesity? Well, again, we have a lot of evidence showing that GLP-1 reduce weight. So GLP-1 based therapy are the first line of therapy for weight loss. And if you can see here on the graph on your right, this is the type of GLP-1s and the percentage of weight loss. And as you can see, the tirzepatide has the most important weight loss percentage reported. If you have no diabetes and no cardiovascular disease, it is the choice of therapy. It is the preferred agent to start with. If they have, the patients have, in addition to obesity, cardiovascular disease is going to be semaglutide. And if there's cardiovascular, if there's diabetes and obesity only with no cardiovascular known disease or risk factors, family history, and so on, then we will start as well semaglutide or tirzepatide. Is there other indication for the GLP-1? Yes. So many studies, as you can see, the SELECT trial was a big one in 2023, showing that semaglutide improved the risk of cardiovascular complications in patients with diabetes. Then chronic kidney disease, yes. So semaglutide with the FLOW trial, semaglutide has a positive effect in stopping or improving chronic kidney disease and type 2 diabetes. How about metabolic dysfunction and liver fibrosis? Oh, well, yes, we see that the tirzepatide was shown to actually improve metabolic dysfunction, people with MASLD, with fatty steatosis, and so on. So really, as you can see, it seemed like obviously a very good drug. And then now the most recent, the Essence trial study group in 2025, so in April of this year, showing that it may have an improved effect on steatohepatitis as well. So as you can see, not only diabetes and obesity, but it seems that there's some benefit in cardiovascular disease, chronic kidney disease, metabolic liver disease. And the hepatologists are actually quite excited about that, and I totally understand that. So let me show you the thumbs up first. So the good side about the GLP-1 that I just summarized earlier, and then we'll talk about the downsides that we know about it. Oh, I have something in the chat. Okay, all good. So in summary, the GLP-1 receptor agonist will act on the brain, the heart, the pancreas, the liver, and the GI, the GI system. In terms of the brain, decreasing appetite, increasing satiety, which some preliminary studies said that with those with some of the effect of body decreasing body weight, increasing blood brain glucose transfer, and so on, there might even have an effect on the cognitive impairment. So decrease the risk of having cognitive impairment in patient with risk, which in sense in a which could make sense in a way because people with hypertension, diabetes, cardiovascular disease are at increased risk of vascular dementia. So these are all hypotheses still, but definitely decrease body weight will have a positive impact on hypertension, decrease insulin resistance, have cardioprotection, better glucose control, and hopefully, and what the newest discovery, all masled improvement. Now, what are the downside or the side effect of GLP-1? So no drug is perfect, as you can imagine. So the most common side effect is actually gastrointestinal side effects. So vomiting, nausea, diarrhea, abdominal pain, and so on. In terms of renal cardiovascular, it can, when associated, there might be some acute kidney injury associated to it, especially when you started, and that's why it's important to do some blood work. There's obviously possible hypersensitivity, but in terms of the pancreas, which is more interesting for you, it's possible pancreatitis. So few reported cases of pancreatitis, cholelithiasis with rapid weight loss and elevated pancreatic enzyme. And hypoglycemia for the diabetes, and some obviously dermatological side effects such as erythema, rash, and alopecia. Now, it's going to be really important to mention that there are absolute contraindication to GLP-1. So first of all, if there is a family history or personal history of middle thyroid carcinoma or a neuroendocrine tumor type 2. So these are contraindication because there is we think that there's an increased risk of thyroid cancer with that therapy. If there's history of hypersensitivity, and the other major thing, especially for us in internal medicine, is pregnancy. So pregnancy and breastfeeding is a absolute contraindication right now. There's a lot of other contraindications that are not absolute, that are relative, such as previous history of pancreatitis and so on. But this is really case to case, and it's more a personalized approach that should be taken in order to see whether the patient is eligible for that therapy. Just to tell you, just a few words. So in terms of coverage, RAM-Q coverage, so the semaglutide currently is covered by RAM-Q for diabetes only and not for obesity. The tirzepatide is also, it's actually not covered right now, whether it's for diabetes or hypertension or obesity, and I looked it up now. However, it is covered by private insurances if you have some, and mainly for diabetes, and if you have obesity at the same time. But for only obesity, the public coverage tend to not cover for it, unfortunately. Well, I don't know if they do recognize obesity as a major issue in a chronic disease, but unfortunately, it's mainly for type 2 diabetes, but private insurances are more flexible in that situation. So let's talk about perioperative use of GLP-1. And one thing that I think before we go ahead and show you the evidence and so on, I just want to discuss what are the implications of having GLP-1 around the surgery. So there's anesthesia implication and there's perioperative consideration. So this slide is basically the assumptions that everybody had when those drugs went on the market, on the perioperative care, based on all the effect or the impact that I just mentioned to you. So the assumption that we have are that in patient on GLP-1 and delayed gastric motility, there will be an increased gastric content that could lead to a higher rate of aspiration. There's an increased risk of post-op nausea and vomiting. One other thing that we think or we were thinking is that if we stop our GLP-1 before surgery at a certain time, it will recover or decrease its effect on gastric motility, hoping that when the patient comes for surgery, that impact might not be as important. The other element is that GLP-1 helps in maintaining glycemic control perioperatively, and that medication reinitiation, if we stop that drug before surgery, need to be done in a re-escalation phase, meaning that when we start those drugs, because of their side effect, we start a small dose and we increase gradually after few weeks, months. And if we stop it before surgery, then we have to do a re-escalation of the doses. So let's see what the evidence have shown. So these are early, I would say early in 2023, but early evidence of when the drug was when the start being on the market in North America, in Canada, and in other places. There were some studies that started coming up, especially studies related to endoscopy, so gastroscopy mainly. And this is one example of study of 1,000 patients with that type 2 diabetes undergoing G-scope. They matched two cohort of about 200 patients and showing that patient on GLP-1, even if they were fasting 12 hours before surgery, there was clear gastric residue. So 5.4% versus 0.5%. Okay. And this has been shown in different other study. Again, 2023, G-scopes, upper endoscopy, single study, retrospective. They did a G-scope in people undergoing under deep sedation or GA, and they compared the patient that took semaglutide within 30 days prior to surgery, prior to G-scope, sorry, versus those that were not on semaglutide, and they showed that as you can see, there's an increased residual gastric content in 24.4% in the semaglutide group versus 5.1% in the non-semaglutide group, and there was one case of aspiration in the semaglutide group. So based on, and then there's, oh yeah, and there's their case report that start coming up of not only that the residue is increasing, but also there's risk of aspiration. So this is some of, again, 2023 regurgitation under anesthesia in a fascist patient. The other one is a pulmonary aspiration in patient with semaglutide. So a lot of case reports starting being published about the fact that people are having aspiration pneumonia. So based on the reports that were coming out in 2023, the Canadian Anesthesiology Society recommendation regarding GLP-1 is that 7-day half-life would likely necessitate to stop it, sorry, I should say, and that 7-day half-life would likely necessitate a prolonged period, weeks of medication cessation to clear their effect. So true, but how realistic is that before surgery, before semi-urgent surgery? Not sure. And as you can see here, these are the half-lives of those medications. Semaglutide is 1 week, okay? Tirzepatide is 130 hours, so almost a week as well. So they have a very long half-lives. In 2023, again, the American this time, what they said is, okay, well, we don't have a lot of information. There are reported cases of aspiration and so on. So what we suggest is you hold the GLP-1 agonist on the day of the procedure and the surgery. For patient on once weekly dosing, consider holding GLP-1 agonist a week prior to surgery. Okay, and that's regardless whether it's for diabetes control or weight loss. And that's what the American have suggested. So then there's more evidence start coming out to say, okay, these are the assumed impact. What are the reported impact now? So few small study, retrospective, observational studies start coming out. And one of the assumed impact is that if we stop it a week before surgery, well, most likely the gastric motility will resume, maybe still reduced, but better than if we don't stop the GLP-1. Well, several studies showed that stopping GLP-1 7 to 14 days prior to surgery was still associated with a persistent residual gastric content. So if holding for patients without GI symptoms such as nausea, vomiting, abdominal pain, holding them at least 21 days was the observed timeline was the observed timeline, so that the observed gastric content was similar to people who were not on GLP-1. And if you did not have any GI symptom, it was at least 14 days. So perhaps the 7 days that we're stopping, that we stop right now is a false kind of reassurance. We tend to be reassured, but maybe it's actually, yes, maybe helping, but not helping enough. So that's something to keep in mind. And then the other assumed impact that I mentioned earlier is that there's an increased risk of aspiration. Well, again, observational study retrospective did not show that. In fact, while there's an increased risk of residual gastric content, the aspiration rate were not different in both groups. The aspiration rate was as low as 0.07%. So I said, oh, interesting, right? So I went and I looked at those papers that say that report this, and here are there. So again, endoscopy studies, that's number one. Lots of study, 23, these are systematic reviews, observational studies, 77,000 amount of patient. Here, the aspiration event had an odd ratio of 21, which is great, which is huge, but you look at the confidence interval is wide too, telling you that probably the number of event was so tiny that I don't know if you can withdraw any conclusion from that study. And then there's another systematic review, again in endoscopy, 13 patients, 84,000 patients. Event rate were 1.75. Confidence interval makes a bit more sense, and the aspiration rate was 0.3%. So those studies obviously are not perfect, is what we have right now, are retrospective. But based on what we have right now, we don't have any evidence that actually the aspiration rate is higher. But again, as I mentioned, studies are not of very great quality, number one. And also, as you can notice, it's all in endoscopy patients, right? Undergoing upper endoscopy. They don't talk about surgery patients. So I decided to do one here to see what's happening in surgery, number one, at McGill. So we are looking at the MUHC and the GGH data right now. It's also a short review, but it's in surgical patient. And we're not only looking at the aspiration rate, but we're also looking at the glycemic control as well. This is something that is lacking in most of those studies. What happened to the glycemic control? Now, you probably got excited because I told you I did something, but it's still ongoing. So I don't have any data for you yet, but I'm just saying that it's happening. We're doing our short review right now. It's hard to find patients on GLP-1, so we have extended our timeline, and hopefully we'll find more patients. But to date, we did not find any case of aspiration. So based on the data that I showed you and the assumed impact and the reported impact, actually the American Anesthesia Society changed their recommendation in October 2024. They said that most patients can continue diabetes, weight loss, GLP-1 drug before surgery. Those at the higher risk of GI problems should follow liquid diet before procedure. So big change, right? From withholding to not holding within a year. And then there were two big publications. December 2024, it's a multi-society clinical practice guideline. So we have the American Society of Anesthesia, the International Society of Periop Care for patients with obesity, and the American Society of Gastroenterology and Endoscopy. At the few months later, we have a more international consensus. So that was published in the British Journal of Anesthesia. And both of those recommendations are saying the same thing, which is the following. Recommendation number one, share decision making of the patient with procedure, anesthesia, and prescribing care team, balancing the metabolic need of GLP-1 with individual patient risk. So basically, we need to more individualize the approach and assess the factor that can elevate the risk of delayed gastric emptying and aspiration. So if the patient has symptoms of when taking his GLP-1 of GI symptoms and so on, these are higher patient with higher risk of of delayed gastric emptying and aspiration. Um, and GLP-1 may be continued preoperatively in patient without elevated risk of delayed gastric emptying or aspiration. And if the decision to withhold the GLP-1 is indicated, to hold it the daily formulation one day and a weekly formulation 1 week. And the recommendation number two is we need to put forward efforts to minimize aspiration risk and delayed gastric emptying. So what is the recommendation is to modify the diet pre-op. So pre-op liquid diet for 24 hours. And when clinical concern for retrained gastric content, to do a point of care gastric ultrasound that Dr. Pon will discuss. And when clinical concern of gastric content, engage patient in a shared decision-making model to discuss risk and benefit of rapid sequence intubation. So again, the British Journal of Anesthesia put it in a nice figure here. Patient taking GLP-1 without significant symptoms, with significant symptoms. If you have no significant symptoms with GLP-1, then you can continue your GLP-1 without interruption. You need to fast 24 hours before fasting for solid. So you can only be, or you should be on clear fluids for 24 hours before surgery. You should be fasting for high carbohydrate content liquids for 8 hours. So that's more than 10% glucose. And fasting for no or low carbohydrate content clear liquids for 4 hours before surgery. If you have significant symptoms, GI mainly symptoms, as you can see here, severe nausea, vomiting, inability to tolerate oral intake, then delay surgery and refer to prescribing physician for diet and medication modification. So an example of instruction that they have put forward, it's something that you give to the patient, telling them exactly what I just mentioned to you, with example of what is clear fluids, clear liquids, and what is 10%, less than 10% carbohydrate liquids. So in summary, the Canadian guidelines and up to date right now are still did not change their guideline. It's to hold one dose of GLP-1. And if the GLP-1 has not been held within that timeline, we have to think about case postponement, cancellation, extend the NPO period, put them on clear fluid before surgery, and avoid deep sedation GA and consider rapid sequence intubation. The American Society, the American Anesthesia Society of Anesthesia, International Society of Periop Care of Obesity, and American Society of Gastroenterology are more suggesting personalized approach to continue the GLP-1 and to fast solid for 24 hours before. So what are we doing here at the MUHC? Well, we're doing a combo of both because we still don't know what we're doing basically. So we're holding the GLP-1 1 week prior to surgery. We are telling the patient to be on clear fluid 24-hour pre-op, regardless of the symptoms or not, and NPO at midnight. The challenges now is that the pre-op visits sometimes happen in a shorter timeline. So that's something that where we involve anesthesia and see their comfort zone with that. And also there's an increasing number of OR that are done in clinics, such as Ville-Marie and so on. And what are the comfort zone of those anesthesia doing this is still unclear. And we will be having some discussion regarding this in the coming days, actually. So on that note, I will let Dr. Pon take over and discuss the intraoperative management of patient on GLP-1. And I'll be your your support, Dr. Pond. So let me know when I need to advance the slides.
Perfect, thank you. Yeah, so as Dr. Bessissow was saying, this is also important for us to not only in like the days leading up to the surgery, but also it's really important for us to know how to manage this on the day of surgery, because these patients we're seeing more and more frequently. And to be honest, it is patients that we're quite uncomfortable with in anesthesia just because of the lack of literature and the high risk nature of these patients. So in an ideal world, everything would be held, the patient would be properly fasted, according to all of the points that Dr. Bessissow had discussed. But also we're seeing patients who come on for emergency surgery who aren't properly optimized, and we need to know how to deal with those patients as well. So we can go to the next slide here. So just kind of to reinforce for everybody the comparison for the standard fasting guidelines compared to the new recommendations from the consensus guidelines. So standard fasting guidelines, they changed a couple of years ago. So now patients are considered NPO after 6 hours after eating any solids, 4 hours with breast milk if you're in the pediatrics world, clear fluids 2 hours. So they kind of shortened all of those fasting times recently for normal standard patients. And then just to kind of reinforce what the new recommendations are on the next slide here with that nice graph. So they're saying for these patients who are on the GLP-1 receptor agonists, they should be off of solids for 24 hours to be considered properly NPO, and kind of on a clear liquid diet for those 24 hours. And for clear fluids, it'll depend on the carbohydrate content, but sometimes between 4 to 8 hours is when they would be considered properly NPO. And this is for patients who are on the GLP-1 receptor agonists that doses have not been held. But in the case that we are still worried about the aspiration risk for these patients, what do we do? So as you guys are well aware, RSI, rapid sequence intubation, is something that's been a part of anesthesia practice for quite some time now. And we do for a lot of your patients, the bowel obstructions, the esophageal patients who are really considered high risk for aspiration. So the indications for RSI outside of these medications, full stomach, so we see it in trauma all the time, emergency surgeries, unfasted patients, pregnant patients are considered full stomach. This is because it lowers the tone of the lower esophageal sphincter. Symptomatic GERD, patients who are known for big reflux, anything that would cause gastroparesis or anything that would obstruct normal outflow from the GI tract. These are patients that we consider high risk for aspiration and that we'd RSI. And as a refresher for everybody who maybe hasn't been doing these cases or been inducing these patients recently, RSI includes predetermined doses of medication. So we're not titrating our inductions, we're just kind of pushing the medications bang, 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 and waiting the appropriate time for it to work instead of like a slow induction. 2 suctions at the head of the bed. You can elevate the head of the bed to roughly 30 degrees to help prevent aspiration of the gastric contents should they vomit. And then you're using either succinylcholine or a intubating dose of rocuronium. So rocuronium at a normal dose, which is 0.6 milligrams per kilogram, takes about 1.5 to 2 minutes for it to really kick in the paralytic effect. But if you go 1 milligram per kilogram, then you can reduce that to about 30 seconds to a minute for it to take effect, or succinylcholine usually takes effect within 30 seconds. So we're really just trying to reduce that time with an unprotected airway where the gastric contents could be aspirated. So we can go to the next slide here. But how can we like guide our decisions? Do we need a RSI? Do we not? Is this patient high risk or not? So Dr. Bessissow alluded to this earlier, but it's believed that patients who are symptomatic, so who have nausea, who have vomiting while they're taking their GLP-1 receptor agonists, are higher risk for aspiration. And these are kind of the patients where I would perform the gastric ultrasound. So when a patient rolls up to the OR and I see that they're on Ozempic or a similar drug, honestly, my heart kind of like sinks a little bit. I know a few of my colleagues feel the same way. So first thing I do is I check whether the dose has been appropriately held. Second thing is I ask them about their symptoms. So if they're feeling any nausea or vomiting on that day of surgery when they come outside the OR. And then if the patient is having that nausea or they're feeling like kind of full stomach, the satiety that Dr. Bessissow was talking about, then those are the patients when I would perform the gastric ultrasound. So we're not performing this on every single patient who is taking these medications. It's kind of targeted to those patients who we feel may be higher risk or we're unsure whether they still have residual gastric contents. So how do we perform this gastric ultrasound? So it's difficult to image the entire gastric body at the same time because of air. And the fundus can be very difficult to image properly. So normally we try to image the antrum and the pyloric regions. The consensus is kind of that the antrum is the best area to be evaluated by ultrasound. And we can look at the quality or like the characteristic of the stomach as well as the size of the stomach to tell us whether this patient is high risk or not for aspiration during this procedure. You can perform the scan in the axial or the sagittal plane if you go to the next slide. I have one more image here. And I find that the sagittal scan is a little bit easier to perform. The axial scan, you can help locate the antropyloric and duodenal transition, but it's a little bit more challenging to locate the exact image that you want. So if you go to the next slide here, so I'll just talk about how the sagittal scan is done. And this is the one that really we do use outside of the OR. So to start the sagittal scan, you kind of start in the epigastric region in the left subcostal margin, and then you fan towards the right to the right subcostal region. And what you're really looking for is you're looking for the body of the stomach, the antrum, and the pylorus. You should be able to sequentially see them. But really your big landmarks that you're looking for is the left lobe of the liver. So that should be cephalad to the antrum. And you can see it, it's demarcated with an L on the left side of that image there. The right under that liver edge is the antrum of the stomach, demarcated with an A. Right there. Yes, thank you for hovering your mouse there, Dr. Bessissow. And then immediately posterior to that on your image, so lower down on the image, you should have the pancreas, which is the P, and the superior mesenteric artery there, which honestly we rarely see, or we don't see it in every patient. But if you can see that, then that's like your perfect image. What we really look for is the aorta, which is even more posterior to that on the image. So the landmarks that I'm looking for are, just to kind of reiterate, is the liver edge and the aorta, and those are the things that we're like reliably going to see in order to know that we have a good image. And then if you can get the pancreas or the SMA, then you're even better. All right. So it should be noted that if you click one more time on the slide here, that the sagittal scan is only considered complete if you scan the patient both in the supine position and the right lateral decubitus position. So it's an incomplete exam if you only scan them supine. And that's because in the right lateral decubitus position, the gastric content is expected to gravitate towards the antrum. So even if you see a safe stomach in the supine position, you need to turn the patient right lateral decubitus and perform the exam there as well, because you may be grossly underestimating the gastric contents if you only scan in the supine position. Okay, so then what exactly are we looking for once we do have our beautiful image here? So the first picture here is an empty stomach. So this is like perfect. This is textbook what we would want to see. So again, you have your liver edge there, and then you just have your antrum. And the antrum appears small and flat in an empty stomach, and it'll be about 2 to 3 centimeters in diameter. It can be like perfectly circular around, or it could be oval, but it kind of appears as this bullseye target. So you have this this hypoechoic demarcation around a more hyperechoic. This happens in about half of patients who are properly fasted, where no appreciable gastric content is present. And by definition, this is very low risk. Sorry, there's just a chat here. Okay, perfect, thank you.
Sorry, next slide.
Yeah. So the next thing that you could possibly see is a stomach with clear fluids. So again, same landmarks here: liver edge, aorta, antrum, SMA. But a stomach with a clear fluid, it'll appear to be totally anechoic or hypoechoic, and it's pretty easy to recognize. It'll almost look like a blood vessel for those of you who are used to doing central lines or any vascular access. So interestingly enough, you can see this in half of patients who are properly fasted. So they'll have appreciable clear gastric secretions, and it appears homogeneous and hypoechoic. There is a chart that you can compare your circumferential surface area to. So you can take the circumference of the antrum and figure out what the area is at this cross section. And then there's a chart that compares this area to the patient's age and tells you whether the stomach is a high aspiration risk or not, a lower aspiration risk. But the upper limit of normal of gastric fluid volume in fasted patients is about 1.5 milliliters per kilogram. And again, you could just compare with your chart to what your area you find is. So we'll go to the next slide here. So next we have a gastric ultrasound with thick fluids or solids. So this would be something like milk or yogurt. And this is something that we don't really want to see. And what you see is kind of this hyperechoic and homogeneous looking stomach in the antrum. And it's not really, should not be present in any patient who is fasting, regardless of how much volume you see. So even if the stomach is small, but you see this characteristic, where it's like a fully hyperechoic and homogeneous looking stomach, then this is a patient who would be a higher aspiration risk and should be managed as such. Then lastly, we have a stomach that is a full stomach with a solids. So this is described as kind of a frosted glass appearance. So this is because the gastric contents is a mixture of solids and air. So you actually don't see a well-demarcated antrum. So there's air trapped along the anterior wall of the antrum, and this creates an artifact that obscures the visualization of the posterior wall. So you may feel like you're not getting a good image, but it's just an artifact of the air and the food obstructing your like perfect view that you would want to see. So this is what we would see in patients who are not fasted, who've had a recent solid meal. And again, this patient obviously is at a high risk for aspiration. So I guess take-home messages. There's a lot of information coming out around these drugs, but we know that they're effective therapies for diabetes and weight control. But despite those good points, they do delay gastric emptying, and for surgical patients can increase aspiration risks. So like Dr. Bessissow said, we don't really know what we're doing, but the current guidelines are for patients who are elevated aspiration risks. We should hold one dose of medication before elective surgery, considering the risk-benefit profile of each individual patient. And this is according to this like multi-organizational consensus guideline. But the Canadian Anesthesia Society is still recommending to hold at least one dose for all patients on these medications. And then for these patients who are taking these medications, extending the fasting times for all patients. So 24 hours on clear fluids with no solids. And then depending on the dextrose contents of those fluids, either 4 or 8 hours for the high carbohydrate versus the low carbohydrates. And then if doses are not properly held, consider delaying the case if possible. We know that's not always possible based on the nature or emergence of these procedures. And if we do have to do the case, we should treat all these patients as full stomach or perform gastric ultrasound to guide our practice. But as always, more research is needed in this field as it's a new and emerging hot topic.
Thank you, Gwen. We are ready. Thank you all for your attention. We're more than happy to take any questions. So let me just come out, and I saw a question in the chat loop. Sorry,
Thank you both for such a comprehensive and well-researched, well-presented review of this topic, which um, leaves us, I guess, with a better understanding of why the approach has been confusing, because I think we're all still navigating this together, trying to figure out what the best thing to do for our patients is. Um, Nancy, if you're still here and you want to make your comment personally, or if you've already read it in the chat and you want to comment on the sort of this post-op ileus. I'm not sure. Yeah, I think she's here, but so I'll just read it out just because maybe it's not everybody has read it. So as a colorectal surgeon, I'm always worried when I see a patient pre-op on Ozempic. They always seem to have a prolonged post-op course with prolonged ileus and difficult glucose control, and they often improve on Maxaran, which points to maybe the gastric dysmotility. And she always thought it was related maybe to the diabetes, but probably it's the drug.
Sorry, hi. I was just walking into the building.
No problem.
Yeah, I've always dreaded Ozempic pre-op when I see my patients, and I never really understood why I dreaded it, but now I kind of do. And like I said in the chat, I always find I'm struggling with a post-op ileus and glucose control. I'm always calling on endo to correct. My last patient I operated on, they held the Ozempic for 2 weeks, and then they did all kinds of weird things with their glucose management. And I really had a difficult time post-op with him, which is exactly what I'm expressing right now. So it's giving me a bit of insight as to what's going on with these patients.
Yeah, so that I absolutely. So there may be a combination, a poorly controlled diabetic patient with gastroparesis and so on, but it might all be also the medication or a combination of both. But definitely the medication, semaglutide is definitely contributing to this. And again, I didn't really touch based on the glucose control because we don't have much time on that, but as I mentioned, most of the study were done on upper endoscopies, so not surgeries and post-op course and so on. And that's what we're hoping to gather some information with the study that is ongoing right now at McGill. But I mean, it makes a lot of sense that obviously the diabetes is not well controlled in those patients. Importantly, is that when we stop the GLP-1, 2 weeks, 3 weeks now, or even more before surgery, we need to give them a rescue management for the diabetes. That's for sure, because we know how the negative impact of hyperglycemia is on surgical outcomes. So, um, excuse me. So definitely challenging medication, as you can see, with not all the answers. I think in the coming years we'll be able to maybe have a bit more answers, but we're all trying in our end, trying to get some information to improve or to change our management. But at this time and point, it's more questions that we have than answers.
Yeah, I think it'll also be interesting to see, as we accumulate more data and look maybe even at the post-operative outcomes, the healing, depending on the different kinds of surgeries and different outcomes, maybe there's also an impact on, cancer outcomes, on recurrences of hernias, on all kinds of different things that we sort of haven't even thought of looking at yet in terms of these drugs. So I think it's really interesting. Roger, you have a question? Go
Sorry,
ahead.
that was a great talk and a great review. And in my former life, patients on some GLP-1 agonists was contraindicated if you had nodular thyroid disease because of the association with the medullary carcinoma of the thyroid. Medullary carcinoma of the thyroid, it's a fascinating tumor, extremely rare in the world of thyroid, but it originates from the parafollicular or C cells, which are of neuroendocrine origin. So it doesn't surprise me, at least in animal studies, there have been excess incidents of MCT in animal studies. I'm not so sure that has borne out in the general population, with the exception of the MEN syndrome or a patient who had previously been treated for a medullary carcinoma of the thyroid. I would be very loath to recommend it in those patients. But when these drugs first came out, it was quote, contraindicated by my medical colleagues to recommend a GLP-1 agonist for anybody with any degree of nodular disease in the thyroid. Well, nodular disease of the thyroid is as common as dirt. 50% of women over the age of 50 will have nodular thyroid disease. So just a comment, nice to see, at least in the thyroid world, by the time I finished up, we were less excited about patients on GLP-1 agonists. But wonderful conference. I'm glad I got out of bed early today to listen to you guys.
Thank you. Thank you for your comment. Thank you.
Barry Stein, I have a question. Can you hear me?
Yep,
Yes.
go ahead.
Yeah, perfect. So for conscious sedation, colonoscopy, gastroscopy, so GERD and it's
We lost you. Oh, we can't hear you, Dr. Stein. If you want to type it.
You can either, whenever you get a better connection, speak up, or you can try to put it in the chat if you have a question, Barry. Anybody else? I'm looking for hands, or just speak up if anybody has any other questions, comments. Anything else? Barry, any chance you're back on track?
oh, sorry.
There.
Where did I mute?
Pretty much conscious sedation.
I was just saying for colonoscopy. So GERD is extremely common from, it's a wide spectrum. So when we do colonoscopy, we have patients NPO for we have them on liquid diet for 24 hours, and they're not really NPO. And for gastroscopy, they're only NPO from the 12 hours beforehand. So would you say for colonoscopy, being on the liquid diet for the 24 hours is adequate? And for gastroscopy, sorry, there's just noise around me. And for gastroscopy with GERD, that 24 hours of liquid diet is enough?
So based on, again, as I mentioned, there's limited evidence, as you have that I alluded. Hi, we see you now. So I definitely would say that the recommendation now, including the American Gastroenterology Association recommendation right now, is for patient without symptoms, meaning that they don't have a symptoms of, I mean, if they all have GERD, it becomes a bit like it's very difficult because there's a kind of a symptom that could be associated to GERD itself or could be associated to the drug therapy, which is to the GLP-1. So it's very difficult to distinguish what is causing what. So in that case, I would treat them as patient with symptoms, to be cautious, and I would tell those patients to stop their GLP-1 before their surgery, before their endoscopy, to hold it, plus 24-hour of clear fluid before surgery. That's what I personally would suggest. If they have symptoms, if they have GI symptoms that could or could not be related to the GLP-1 receptor agonist.
Yeah, perfect. I'm there's a massive spike in GI complaints that people come in for consults. I see so much of it since this drug.
Yeah, I believe you. I believe you, and I think it should be, when we do a G-scope request and we send it out, we have at the lower part, we have indications whether they're anticoagulated, whether they're diabetic, and so on. And if I'm not mistaken, Dr. Stein, there's no area to say whether the patient is on GLP-1 or not. So we give recommendation regarding the anticoagulation, but not on the GLP-1. And I think this is something that we should consider adding to minimize what you're having in terms of cases that are being maybe
Missed.
canceled or postponed. So I think it's
Yeah.
something to consider adding it in that form.
Perfect. Thank you very much. Great presentation.
Great, thank you.
So yeah, I guess we're out of time and people have to run off to do their various things. But thank you to you both. I think this was a really a great presentation, very timely, and thank you very much for all the work that you put into it. And
Thank you.
our
Thank you for having us.
questions.
Thank you so much. Have a
you.
good one, everyone. Bye-bye.
Bye.